A 6-year-old boy is brought to the ER by his parents after experiencing a generalized tonic-clonic seizure. His parents report that the child had no prior history of seizures but was recently diagnosed with a viral infection. He presents with a low-grade fever and lethargy. What is the most likely diagnosis and what is the appropriate management for this patient? Answer: the most likely diagnosis in this case is febrile seizure, which is a common seizure disorder in children aged 6 months to 5 years. Febrile seizures are typically associated with fever but without evidence of CNS infection or other causes of seizures. Diagnosis: febrile seizures are categorized into two types: simple febrile seizures, generalized seizures lasting less than 15 minutes with no recurrence within 24 hours, complex febrile seizures, focal lasting more than 15 minutes or occurring more than once within 24 hours. This case is suggestive of a simple febrile seizure. Management: initial management involves ensuring the airway, breathing, and circulation are stable. Antipyretics such as acetaminophen or ibuprofen may be used to control fever, although this does not prevent recurrence. Reassurance of the parents is essential, as febrile seizures are generally benign and do not indicate epilepsy. A 2-year-old girl presents with pallor and irritability. Her dietary history reveals that she drinks large quantities of cow's milk. Her hemoglobin level is 9.5 grams still, and her mean corpuscular volume (MCV) is 72 FL. What is the most likely diagnosis and what dietary modifications should be made? Answer: the most likely diagnosis is iron deficiency anemia. Iron deficiency anemia is common in toddlers who consume excessive cow's milk, as it is low in iron and can cause gastrointestinal blood loss leading to iron depletion. Diagnosis: based on low hemoglobin and MCV, the diagnosis of microcytic anemia is confirmed, with the likely cause being iron deficiency. Management: dietary modifications: limit cow's milk intake to less than 24 ounces per day and introduce iron-rich foods such as red meat, poultry, and fortified cereals. Iron supplementation: oral iron therapy should be initiated, typically ferrous sulfate, until the hemoglobin normalizes, followed by an additional 3 months of treatment to replenish iron stores. Monitoring: a follow-up hemoglobin check should be done after 1 month of iron therapy to assess the response. Mr. and Mrs. Peterson bring their 5-day-old newborn to the clinic, concerned about his yellow skin. The infant was born at 38 weeks gestation, is breastfeeding well, and has no signs of illness. His total serum bilirubin level is 4 mdl with a direct bilirubin of 0.3 mdl. The infant is otherwise well-appearing and has no history of significant weight loss. What is the most likely diagnosis and how should this case be managed? Answer: the most likely diagnosis is physiologic jaundice of the newborn, which occurs due to increased bilirubin production, decreased hepatic conjugation, and increased enterohepatic circulation in the first week of life. Diagnosis: physiologic jaundice typically presents after 24 hours of life, peaks on days 3-5, and resolves by 1-2 weeks. In term infants. Management: reassurance: since the infant is feeding well and bilirubin levels are within the normal range for age, this is likely benign physiologic jaundice. Continue breastfeeding. Encourage frequent breastfeeding, 1-2 times per day, to promote bilirubin excretion. Monitoring: bilirubin levels should be monitored to ensure they do not exceed the phototherapy threshold. No intervention is needed unless the bilirubin level rises rapidly or there are signs of pathology, e.g. direct bilirubin to EDA. A 5-year-old boy presents with fatigue, easy bruising, and recurrent infections. His physical exam reveals pallor, petechiae, and hepatosplenomegaly. A complete blood count shows pancytopenia with blasts on the peripheral smear. What is the most likely diagnosis and what is the next step in management? Answer: the most likely diagnosis is acute lymphoblastic leukemia, or the most common childhood malignancy. Diagnosis: ALL is suggested by pancytopenia, circulating blasts, and hepatosplenomegaly. Confirmation requires a bone marrow biopsy showing 20% lymphoblasts. Management: immediate hospitalization is required for further diagnostic evaluation and initiation of treatment. Chemotherapy is the cornerstone of treatment and typically involves induction, consolidation, and maintenance phases. Prognosis: with modern therapy, the 5-year survival rate for childhood ALL exceeds 85%. A 4-year-old unvaccinated boy presents with a 3-day history of fever, cough, coryza, and conjunctivitis. Examination reveals a maculopapular rash starting on the face and spreading to the trunk. Small white spots are noted on his buccal mucosa. What is the most likely diagnosis and what public health measures should be taken? Answer: the most likely diagnosis is measles, rubiola, a highly contagious viral illness characterized by the 3CR, cough, coryza, conjunctivitis, fever, and a maculopapular rash. Diagnosis: Clinical diagnosis is supported by the presence of Koplik spots, white spots on buccal mucosa. Management: supportive care with hydration and antipyretics. Vitamin supplementation in children with severe measles has been shown to reduce morbidity and mortality. Public health measures: measles is a reportable disease, and local health authorities should be notified to initiate contact tracing and isolation measures. Post-exposure prophylaxis with the MMR vaccine or immunoglobulin should be considered for at-risk contacts. A premature infant born at 28 weeks of gestation requires resuscitation immediately after birth. What are the key steps in the neonatal resuscitation protocol, and what considerations should be taken regarding the infant's gestational age? Answer: for a premature infant, the key steps in neonatal resuscitation are outlined in the Neonatal Resuscitation Program (NRP) guidelines. These steps include 1. Preparation. Ensure that all necessary equipment e.g. radiant warmer, suction, bay mask, ventilation device, intubation equipment is ready and functional before delivery. 2. Initial assessment. Assess the infant immediately after birth, focusing on Apgar score at 1 and 5 minutes, heart rate. If 60 beats per minute, initiate resuscitation. Breathing effort. Look for signs of respiratory distress, e.g. grunting, retractions. 3. Airway management. If the infant is not breathing effectively, clear the airway with gentle suction as needed. Provide positive pressure ventilation (PPV) with the bag and mask if the heart rate is below 100 beats per minute or if there are signs of respiratory distress. 4. Supplemental oxygen. Administer supplemental oxygen as needed to maintain an oxygen saturation of 90–95%. Be cautious in premature infants to avoid oxygen toxicity. 5. Chest compressions. If the heart rate remains below 60 beats per minute despite adequate ventilation, initiate chest compressions at a ratio of 3:1 with positive pressure ventilation. 6. Medications. If the heart rate remains low, administer epinephrine 0.01–0.3 g mg, a third-line treatment. 7. Advanced airway. If necessary, and if the infant is unresponsive to the above measures, consider endotracheal intubation. Considerations: gestational age. Premature infants, especially 28 weeks, are higher risk for complications like hypothermia, apnea, and respiratory distress syndrome due to surfactant deficiency. Therefore, proactive management to stabilize body temperature and support breathing is critical. And CPAP, continuous positive airway pressure (CPAP), can be used in the delivery room to help maintain functional residual capacity. At what age should a child be expected to say at least 50 words and start combining 2 words into simple phrases? What other developmental milestones should be assessed at this stage, and what are the implications of delayed milestones? Answer: a child should typically be expected to say at least 50 words and start combining 2 words into simple phrases around 24 months, 2 years of age. Developmental milestones. At this stage, other important milestones to assess include gross motor skills, walks independently and may start to run, climbs onto furniture, kicks a ball. Fine motor skills, builds a tower of 2–4 blocks. Scribbles spontaneously. It can undress themselves. Social and emotional development. Shows interest in other children. Parallel play. Exhibits defiant behavior e.g. cognitive development. Follows simple instructions e.g. come here. Identifies common objects and pictures e.g. dog. Implications of delayed milestones. Concern: if a child is significantly delayed in any area e.g. language skills, further assessment by a pediatrician or developmental specialist may be warranted. This could indicate conditions such as language disorders, autism spectrum disorders, or other developmental delays. Intervention. Early intervention programs can provide support and resources, which can significantly improve long-term outcomes for children with developmental delays. A 2-month-old infant presents with failure to thrive, tachypnea, and a continuous machine-like murmur. An echocardiogram reveals a patent ductus arteriosus PDA. What are the implications of this condition, and what is the most appropriate treatment? Answer: the presence of a patent ductus arteriosus PDA in an infant, particularly with symptoms such as failure to thrive and tachypnea, indicates significant hemodynamic implications. Implications: left to right shunt. The PDA causes a left-to-right shunt, leading to increased pulmonary blood flow and resultant pulmonary overcirculation. This can cause symptoms of heart failure, such as tachypnea and poor weight gain. Failure to thrive. Risks: if untreated, this can lead to long-term complications such as pulmonary hypertension and congestive heart failure. Treatment. Medical management. In premature infants, indomethacin, a non-steroidal anti-inflammatory drug, may be administered to promote closure of the PDA by inhibiting prostaglandin synthesis. This is particularly effective in preterm infants. Surgical intervention. If the PDA is significant and causing symptoms in term infants, or if medical management is ineffective, surgical ligation of the ductus arteriosus may be necessary. A 10-month-old infant presents with wheezing, cough, and difficulty breathing. The parents report a history of upper respiratory symptoms for the past few days. On examination, the infant is tachypneic with intercostal retractions. What is the most likely diagnosis and what is the appropriate management? Answer: the most likely diagnosis is bronchiolitis caused by respiratory syncytial virus, the RSV, a common viral infection in infants. Diagnosis: clinical signs such as wheezing, cough, and respiratory distress combined with a history of upper respiratory infection are characteristic of bronchiolitis. Management: supportive care. Oxygen therapy. Administer supplemental oxygen to maintain oxygen saturation above 90%. Hydration. Ensure adequate fluid intake either orally or via IV fluids if the infant is unable to drink adequately. Bronchodilators. Short-acting beta agonists e.g. albuterol may be administered, although their efficacy in bronchiolitis is limited and should be used cautiously. Steroids. The routine use of corticosteroids is not recommended in most cases of bronchiolitis. Monitoring. Hospital admission may be necessary for infants with moderate to severe respiratory distress, dehydration, or those requiring close observation. Preventive measures. Palivizumab Synagis may be given to high-risk infants, e.g. those with chronic lung disease or congenital heart disease, as prophylaxis against RSV during the RSV season. In summary, understanding RSV and its management is critical due to its prevalence in infants and the potential for severe respiratory distress. A 4-year-old boy presents to the emergency department with a witnessed generalized tonic-clonic seizure lasting approximately 3 minutes. His mother reports that he had a mild upper respiratory infection 2 days prior, but otherwise he has been healthy. Neurological examination is unremarkable, and the boy returns to baseline immediately after the seizure. What are the most likely etiologies for this seizure, and what is the appropriate workup and management? Answer: the seizure described is consistent with a simple febrile seizure, which is common in children aged 6 months to 5 years. Given that the child had a mild upper respiratory infection prior to the seizure, this is likely related to the fever associated with the illness. Etiologies: febrile seizures. These occur due to a rapid increase in body temperature, typically above 38 dec 100.4 dec, often caused by infections, viral most commonly. Other potential causes in this age group include metabolic disturbances, e.g. hypoglycemia, electrolyte imbalances, central nervous system infections, e.g. meningitis, and structural abnormalities, but these are less likely given the normal neurological exam and the context of a recent febrile illness. Workup: history and physical examination, detailed history to confirm fever, duration, and characteristics of the seizure, and thorough physical examination to check for signs of infection or neurological deficits. Laboratory tests: complete blood count (CBC) to check for signs of infection, electrolytes to rule out metabolic causes, blood glucose level to exclude hypoglycemia, neuroimaging, and not routinely indicated for simple febrile seizures unless there are atypical features, e.g. focal features, prolonged seizures 15 minutes, or multiple seizures in a short time. If any of these are present, a CT or MRI of the brain may be warranted, along with an EEG for further assessment. Management: immediate management. As the seizure was self-limiting, the immediate focus is supportive care. Postictal care: after the seizure, the child should be monitored until fully recovered. Education: parents should be educated about what to expect in the event of another seizure and when to seek medical attention. Prognosis: the likelihood of recurrence is about 3050% in children with febrile seizures, but the long-term risk of developing epilepsy is low, approximately 1–2%. A 58-year-old male patient presents to the emergency department with severe chest pain radiating to his left arm. His vital signs are as follows: BP 90, 60A, GHR 110 BEM, and respiratory rate of 24 breaths min. What is the most appropriate immediate management for this patient, and what are the key principles behind this approach? Answer: the patient exhibits signs of an acute myocardial infarction, OMI, with possible cardiogenic shock indicated by hypotension and tachycardia. The immediate management should include administering oxygen to improve tissue oxygenation, establishing IV access for medication administration, nitrates, to relieve chest pain and decrease myocardial oxygen demand, aspirin, to inhibit platelet aggregation and reduce thrombus formation, beta blockers. If there are no contraindications, such as severe hypotension or bradycardia, beta blockers should be initiated to decrease heart rate and myocardial oxygen demand. Anticoagulation therapy, unfractionated heparin, should be considered to prevent further clotting. Key principles: early identification and treatment. Recognizing the signs and symptoms of AMI and initiating treatment promptly can significantly reduce mortality and morbidity. Myocardial oxygen supply-demand balance. Managing factors that affect oxygen supply and demand is critical in AMI. Treatments aim to improve perfusion and reduce the workload on the heart. Relevant guidelines from the American College of Cardiology (AC) and American Heart Association (IA) recommend early administration of antithrombotic therapy and continuous monitoring in cases of suspected AMI. A 45-year-old female is admitted to the hospital with septic shock after presenting with fever, tachycardia, and hypotension. After initial fluid resuscitation, her blood pressure remains low. What are the next steps in her management, and how do they align with the Surviving Sepsis Campaign guidelines? Answer: immediate interventions include establish airway and breathing support, ensure the airway is clear and provide supplemental oxygen. If necessary, prepare to assist ventilation due to her decreased respiratory rate. Administer naloxone. Given the suspicion of opioid overdose, administer naloxone (Narcan) to reverse opioid effects. The initial dose is typically 0.4 mg to 2 mg IV/IM or intranasal, repeating every 2-3 minutes if necessary. Flumazenil caution. While flumazenil can reverse benzodiazepine effects, it is generally avoided in mixed overdoses due to the risk of seizures and the potential for rapid withdrawal syndromes in dependent patients. Key principles: understanding pharmacology. Naloxone acts as an opioid antagonist, displacing opioids from receptors and restoring respiratory drive. It is critical to monitor the patient for recurrent respiratory depression due to the short half-life of naloxone compared to opioids. Managing mixed overdose. Careful consideration of the pharmacological interactions between opioids and benzodiazepines is necessary, as both can cause respiratory depression. Mr. Roberts is a 32-year-old man involved in a high-speed motor vehicle accident. He presents with multiple rib fractures, abdominal tenderness, and a decreased level of consciousness (GCS) of 13. Describe the appropriate trauma assessment protocol for Mr. Roberts and highlight the critical points to evaluate based on Advanced Trauma Life Support (ATLS) guidelines. Answer: the trauma assessment protocol should follow the ABCD approach. Airway. Ensure the airway is patterned. Given the decreased level of consciousness, consider intubation to secure the airway. B. Breathing. Assess for respiratory distress and evaluate chest expansion. Supplemental oxygen should be administered, and a chest X-ray may be needed to check for pneumothorax or hemothorax. C. Circulation. Monitor blood pressure and heart rate. Establish IV access and begin fluid resuscitation if signs of hypovolemic shock are present. D. Disability. Conduct a neurological assessment, noting the GCS. Investigate potential intracranial injuries due to trauma. Exposure. Fully expose the patient to assess for additional injuries while maintaining body temperature to prevent hypothermia. Key principles: systematic approach. Following the ABCD method ensures that life-threatening conditions are prioritized and managed appropriately. Continuous monitoring. Regular reassessment is vital in trauma cases to detect any changes in the patient's condition promptly. The ATLS guidelines stress the importance of a structured approach to trauma assessment and management, which can greatly affect patient outcomes. A 70-year-old patient with a history of COPD presents to the emergency department with increased shortness of breath and use of accessory muscles for breathing. Arterial blood gas analysis shows a ECV 7.28, ECO of 6 mg, and PO of 55 mg. What management strategies should be employed, and what are the underlying physiological principles at play? Answer: in this case, the patient is experiencing acute respiratory failure characterized by respiratory acidosis and hypoxemia. The management strategies include supplemental oxygen. To address hypoxemia, however, caution is necessary to avoid oxygen-induced hypercapnia in COPD patients. Bronchodilators. Administering short-acting beta agonists e.g. albuterol can help relieve bronchospasm. Corticosteroids. Systemic corticosteroids e.g. prednisone may reduce airway inflammation. Non-invasive ventilation (NIV). If the patient does not respond adequately to initial treatments, consider initiating NIV e.g. BiPAP to improve ventilation and reduce CO levels. Key principles: understanding acid-base balance. The elevated PCO indicates hypoventilation, leading to respiratory acidosis. The management goal is to improve ventilation and correct the acid-base disturbance. Oxygen therapy risks in COPD. Care must be taken when providing oxygen therapy to COPD patients, as high levels can suppress their hypoxic drive and worsen hypercapnia. A 28-year-old female presents to the emergency department after an intentional overdose of acetaminophen. She appears lethargic with mild jaundice. What are the critical steps in her management, and how do they relate to the pharmacokinetics of acetaminophen? Answer: in managing acetaminophen overdose, the following steps are critical. Immediate assessment. Obtain a serum and acetaminophen level ideally within 4 hours of ingestion to determine the need for treatment based on the Rumac-Matthew nomogram. Administration of N-acetylcysteine (NAC) if the serum level is above the treatment line on the nomogram, or if it is uncertain, NAC should be administered. NAC acts as a precursor to glutathione, helping to restore depleted stores and conjugate the toxic metabolite N-acetyl-P-benzoquinone amine. NAP supportive care. Monitor liver function tests and provide symptomatic care for nausea and potential hepatic failure. Key principles. Pharmacokinetics of acetaminophen. Understanding the metabolism of acetaminophen is crucial. Under normal circumstances, it is primarily conjugated to non-toxic metabolites. However, in overdose situations, the pathways become saturated, leading to the formation of toxic NAPQI. Timely intervention. Administering NAC within 8 hours post-ingestion maximizes its effectiveness in preventing liver injury. The American Association of Poison Control Centers provides guidelines for managing acetaminophen toxicity, emphasizing the importance of early recognition and treatment. A 25-year-old male marathon runner collapses during a race on a hot day. Upon arrival at the medical tent, his temperature is 104 Fahrenheit, and he is confused. What steps should be taken in the emergency management of heat stroke, and what physiological mechanisms contribute to this condition? Answer: the immediate management steps for heat stroke include rapid cooling. Initiate aggressive cooling measures such as ice packs placed on major blood vessels, e.g., axillary, groin, and immersion in cold water if available. IV fluid resuscitation. Administer isotonic fluids to restore intravascular volume and maintain organ perfusion. Monitor vital signs. Continuous monitoring of temperature, heart rate, and blood pressure is essential to assess response to treatment. Key principles. Understanding heat stroke. Heat stroke occurs when the body's thermoregulatory mechanisms fail, leading to hypothermia and cellular dysfunction. The inability to dissipate heat can result in organ failure and potential death. Physiological response to hypothermia. As the body temperature rises, cellular metabolism increases, leading to further heat production and potential breakdown of cellular structures, particularly in the brain. A 60-year-old homeless man is found unresponsive in an alley during winter. His core body temperature is measured at 86 degrees. Describe the management strategies for his condition and explain the physiological consequences of hypothermia on the body's systems. Answer: management strategies for hypothermia include immediate assessment, conduct a thorough evaluation, including vital signs and a physical examination, to assess for other life-threatening conditions. Rewarming techniques. Initiate passive rewarming by removing wet clothing and wrapping the patient in warm blankets. Active external rewarming, e.g., warm water immersion, may be considered in moderate to severe cases. Monitoring and support. Continuous cardiac monitoring is essential as hypothermia can lead to dysrhythmias. Administer IV fluids warmed to body temperature to aid in rewarming and restore intravascular volume. Key principles. Physiological effects of hypothermia. Hypothermia affects the body's metabolic processes, leading to a decrease in heart rate, reduced cardiac output, and impaired neurological function. Potential complications. The risk of arrhythmias increases significantly at temperatures below 86 degrees, necessitating careful monitoring during rewarming. 50-year-old male presents with severe epigastric pain radiating to the back associated with nausea and vomiting. His history includes chronic alcohol use. What are the key diagnostic steps to determine the underlying cause of his symptoms, and what conditions should be considered in the differential diagnosis? Answer: key diagnostic steps include detailed history and physical examination. Assess the onset, duration, and characteristics of the pain as well as associated symptoms. Physical examination should include abdominal tenderness, guarding and rebound tenderness. Laboratory tests. Obtain a complete blood count, CBC, liver function test, LFTS, and serum amylase levels to evaluate for pancreatitis. Imaging studies. Perform an abdominal ultrasound or CT scan to assess for gallstones, pancreatitis, or other intra-abdominal processes. Key principles. Differential diagnosis considerations. Conditions such as acute pancreatitis, peptic ulcer disease, cholecystitis, and perforated viscous must be considered due to the patient's alcohol use and presentation. Importance of rapid assessment. Timely diagnosis and management are crucial in cases of acute abdomen to prevent complications such as sepsis or perforation. During a community event, a bystander witnesses a 45-year-old woman collapse and become unresponsive. What are the critical steps the bystander should take according to the latest CPR guidelines, and how do these steps improve the likelihood of a positive outcome? Answer: the critical steps for the bystander include call for help, immediately call emergency services 911 or direct someone else to do so while staying with the victim. Check responsiveness. Tap the person and shout to check for responsiveness. If unresponsive, initiate CPR. Chest compressions. Begin high-quality chest compressions at a rate of 100-120 compressions per minute, allowing full recoil between compressions to enhance venous return. Defibrillation. If an automated external defibrillator is available, apply it as soon as possible. Follow the AED prompts to analyze the rhythm and deliver a shock if indicated. Key principles: chain of survival. The sequence of immediate action, calling for help, CPR, and defibrillation is critical in improving survival rates after cardiac arrest. Quality of CPR. High-quality compressions are crucial in maintaining blood flow to vital organs until advanced medical help arrives. Mrs. Thompson, a 50-year-old woman, was found in her home with empty bottles of various medications, including benzodiazepines and opioids. She is lethargic with a respiratory rate of 8 breaths-min and a pulse oximetry reading of 85%. What immediate interventions should be taken, and what are the key pharmacological principles guiding the treatment of mixed overdose? Answer: immediate interventions include establish airway and breathing support, ensure the airway is clear and provide supplemental oxygen. If necessary, prepare to assist ventilation due to her decreased respiratory rate. Administer naloxone. Given the suspicion of opioid overdose, administer naloxone Narcan to reverse opioid effects. The initial dose is typically 0.4 mg to 2 mg IV IM or intranasal, repeating every 2-3 minutes if necessary. Flumazenil. Caution: while flumazenil can reverse benzodiazepine effects, it is generally avoided in mixed overdoses due to the risk of seizures and the potential for rapid withdrawal syndromes in dependent patients. Key principles: understanding pharmacology. Naloxone acts as an opioid antagonist, displacing opioids from receptors and restoring respiratory drive. It is critical to monitor the patient for recurrent respiratory depression due to the short half-life of naloxone compared to opioids. Managing mixed overdose. Careful consideration of the pharmacological interactions between opioids and benzodiazepines is necessary, as both can cause respiratory depression. A 67-year-old male with a history of chronic obstructive pulmonary disease (COPD) is scheduled for elective hernia repair. His FEV is 1.2 L, predicted 2.5 L, and his POW is 6 mHg. What is the most appropriate preoperative management to minimize the risk of postoperative pulmonary complications? Answer: the patient's significant COPD increases the risk of postoperative pulmonary complications such as pneumonia and respiratory failure. Preoperative optimization is crucial in reducing these risks. This patient should be evaluated for pulmonary function tests (PFTS) to assess the severity of COPD and predict postoperative ventilatory capacity. Smoking cessation. Smoking should be stopped at least 8 weeks preoperatively to reduce pulmonary complications. Preoperative pulmonary rehabilitation. This includes intensive spirometry, bronchodilators, and potentially a short course of corticosteroids if airway obstruction is severe. Perioperative monitoring and postoperative care. Adequate postoperative analgesia to prevent shallow breathing and atelectasis. Early mobilization and intensive spirometry postoperatively are essential. Guidelines such as the American College of Chest Physicians suggest considering these factors in patients with COPD undergoing surgery. What are the risk factors for deep vein thrombus (DVT) in postoperative patients, and what is the most appropriate thromboprophylaxis for a patient undergoing total knee arthroplasty? Answer: postoperative DVT is a major concern, especially in orthopedic surgeries such as total knee arthroplasty. The primary risk factors include prolonged immobility, major surgery, especially orthopedic surgeries involving the lower limbs, age 60 years, obesity, cancer, prior history of DEE, For high-risk surgeries like knee arthroplasty, low molecular weight HEPA is the standard thromboprophylaxis recommended by the American College of Chest Physicians Act. It should be started within 12 hours postoperatively and continued for at least 1014 days or up to 35 days if the patient has significant risk factors. Alternatively, direct oral anticoagulants, DOACs or warfarin with INR monitoring can be considered. Mr. Thompson, a 45-year-old male, presents to the emergency department after a motor vehicle accident. He has dyspnea, tachycardia, and diminished breath sounds on the right side. His blood pressure is 85/55 Hg and his jugular veins are distended. What is the most likely diagnosis and what should be the immediate management? Answer: Mr. Thompson's presentation is classic for tension pneumothorax, which is a life-threatening condition characterized by air trapping in the pleural space, leading to hemodynamic compromise. Diagnosis: tension pneumothorax is suspected based on the combination of dyspnea, hypotension, tachycardia, absent breath sounds on one side, jugular venous distension due to compression of venous return. Immediate management: immediate decompression is critical and should be performed without waiting for imaging. A needle thoracostomy, 14-gauge needle in the second intercostal space midclavicular line, is followed by insertion of a chest tube thoracostomy to allow for definitive management. Delayed treatment can lead to cardiovascular collapse and death. A 58-year-old female develops fever, erythema, and purulent drainage at her abdominal incision site 5 days after an elective cholecystectomy. What is the most likely pathogen and how should this be managed? Answer: the most common pathogen responsible for postoperative wound infections is Staphylococcus aureus, including methicillin-resistant strains MRSA. Infections usually present with fever, localized erythema, and purulent discharge as seen in this patient. Management: incision and drainage. ID: all purulent material should be drained from the wound. Empiric antibiotic therapy: broad spectrum antibiotics covering gram-positive organisms including MRSA are initiated. Options include vancomycin or linezolid until culture results. Guide therapy: wound care, wound dressing changes, and local wound care are essential in promoting healing. Guidelines from the Centers for Disease Control and Prevention (CDC) recommend antibiotic prophylaxis in clean contaminated surgeries like cholecystectomy, but postoperative infections may still occur due to skin flora. What are the criteria for surgical intervention in an abdominal aortic aneurysm, and what are the risks of not performing surgery in a patient with a 6.2 centimeters AAA? Answer: the risk of rupture in an AAA increases with the size of the aneurysm. Indications for surgical repair include aneurysm diameter 5.5 centimeters in men and 5 centimeters in women. Rapid expansion 0.5 centimeters in 6 months. Symptomatic aneurysms: abdominal or back pain. Evidence of rupture in this patient with a 6.2 centimeters AAA. The risk of rupture is approximately 1020% per year. Elective surgical repair is recommended due to the high risk of catastrophic rupture, which carries a 5080% mortality rate. Surgery can be performed via open repair or endovascular aneurysm repair (VAR), with VAR generally preferred for low perioperative mortality. A 42-year-old female presents with right upper quadrant pain, nausea, and vomiting. An ultrasound reveals gallstones and signs of acute cholecystitis. What factors should the surgeon consider when deciding between laparoscopic and open cholecystectomy, and what are the indications for conversion to an open procedure during laparoscopic surgery? Answer: in cases of acute cholecystitis, several factors must be evaluated when choosing between laparoscopic and open cholecystectomy. Severity of the disease. If there are signs of complicated cholecystitis, e.g. perforation, abscess formation, or gangrene, an open approach may be favored due to better access and visualization. Surgeon expertise. The experience of the surgical team with laparoscopic techniques is critical. If the surgical team is inexperienced or if the patient's anatomy poses challenges, they may prefer an open approach. Patient characteristics. Factors such as obesity, previous abdominal surgeries, or underlying comorbidities can increase the risk associated with laparoscopic surgery, leading the surgeon to opt for an open procedure. Timing of surgery. Early laparoscopic cholecystectomy within 72 hours of symptom onset has been shown to reduce complications and is generally preferred over delayed open cholecystectomy. Indications for conversion to open procedure: inability to visualize the anatomy. If the critical structures, cystic duct, cystic artery, are not clearly identified, the procedure may need to be converted to prevent injury to the bile duct or vascular structures. Severe adhesions. Extensive scarring from previous surgeries can make laparoscopic dissection difficult and unsafe. Excessive bleeding. If there is uncontrolled bleeding that cannot be managed laparoscopically, conversion to open surgery may be necessary. Guidelines from the Society of American Gastrointestinal and Endoscopic Surgeons (SAGES) recommend early intervention and careful assessment of patient and disease characteristics in determining the surgical approach. A 35-year-old male presents with respiratory distress following a motorcycle accident. Physical examination reveals decreased breath sounds on the right side and tracheal deviation to the left. What is the likely diagnosis and what are the critical steps in management? Answer: the clinical findings suggest a tension pneumothorax, a life-threatening condition that occurs when air enters the pleural space and is trapped, leading to increased intrathoracic pressure, respiratory compromise, and cardiovascular instability. Management steps: immediate decompression. Perform needle decompression using a large bore cannula 14 gauge at the second intercostal space in the midclavicular line on the affected side. This relieves pressure in the pleural cavity and restores venous return. Chest tube placement. After needle decompression, place a chest tube thoracostomy in the fifth intercostal space along the anterior axillary line for continuous drainage of air or fluid. Oxygen therapy. Administer supplemental oxygen to improve oxygenation. Monitoring. Continuous monitoring of vital signs and respiratory status is critical. Observe for signs of improvement or deterioration. Definitive management. After stabilization, further imaging such as chest X-ray or CT scan may be needed to evaluate for additional injuries or confirm the diagnosis. A 60-year-old diabetic patient develops a fever and purulent drainage from a surgical wound 2 weeks after colon resection for cancer. What pathogens are most likely responsible for this infection, and what is the appropriate antibiotic management? Answer: surgical site infections (SS) after colon surgery often involve polymicrobial flora including gram-positive cocci, Staphylococcus aureus including MRA, gram-negative rods, Escherichia coli, Klebsiella species, anaerobes, bacteroids, and Clostridium species. Management: culture and sensitivity testing. Obtain a wound culture to identify specific pathogens. Empiric antibiotic therapy. Initiate broad-spectrum antibiotics to cover common pathogens. A typical regimen may include piperacillin, tazobactam, or meropenem for polymicrobial coverage. Vancomycin may be added for MRSA coverage, especially in patients with risk factors for resistant organisms. Wound management: surgical intervention may be necessary for drainage of abscesses or debridement of necrotic tissue. Blood glucose control. In diabetic patients, controlling blood glucose levels is critical in reducing the risk of SS. A 50-year-old female presents with complaints of aching pain in her legs, especially after standing for prolonged periods. Examination reveals swollen, tortuous veins in the lower extremities. What is the best initial diagnostic test to confirm the diagnosis of chronic venous insufficiency (CEA), and what are the management options? Answer: the best initial diagnostic test for evaluating chronic venous insufficiency and varicose veins is duplex ultrasonography. This non-invasive test assesses venous anatomy and function, identifying venous reflux and obstruction. Management options: conservative measures, compression stockings. Graduated compression therapy helps reduce symptoms by improving venous return. Lifestyle modifications, weight loss, exercise, and leg elevation. Interventional procedures. If conservative measures fail or if the patient has significant symptoms or complications, intravenous laser therapy, EVLT, or radiofrequency ablation (RFA). Minimally invasive techniques for treating varicose veins. Sclerotherapy involves injecting a sclerosant into the veins to occlude them. Surgical options: ligation and stripping of the affected veins may be necessary in severe cases. 55-year-old male with a history of hypertension and hyperlipidemia is found to have a 5.5 centimeters abdominal aortic aneurysm during a routine ultrasound. What factors should be considered when planning for surgical intervention, and what are the risks associated with not repairing an AAA of this size? Answer: in a patient with a 5.5 centimeters AAA, several factors must be considered prior to surgical intervention. AAA size. Repair is generally indicated for AA as 5.5 centimeters due to the significantly increased risk of rupture, which can lead to a mortality rate of 5080%. Symptomatic versus asymptomatic. Symptomatic AA is e.g. pain, tenderness, require urgent intervention, while asymptomatic AAs can be scheduled for elective repair. Patient comorbidities. Assessing the patient's overall health, including cardiovascular status, is critical in determining surgical risk. Comorbidities may necessitate optimization before surgery. Surgical approach. Determine if an open surgical repair or endovascular aneurysm repair of art is more suitable based on anatomy, patient preference, and surgeon experience. The risks of not repairing a 5.5 centimeters A rupture risk. The annual risk of rupture increases with size for a 5.5 centimeters AAA. It may reach 10% per year. Mortality. Ruptured AAA has a high mortality rate with up to 80% dying before reaching the hospital.